Our first speaker this morning is Solange Frost from the New South Wales Council of Social Services. Solange is a Senior Policy Officer who looks after their health area, and she'll be giving us a big overview of health reform in Australia, and it's a big picture thing, so it's not specific to youth health.
Good morning. As Jason said, I'm Solange Frost and I work at NCOS, we're the Council of Social Service New South Wales. And apologies, I did give a similar presentation to some of you a few months ago at the advisory committee, so if it's a similar content, please bear with me. I'd also probably add the disclaimer in that as a NGO, we don't work directly for government, so I'm coming really from an outsider's perspective looking in on the reforms, and I'm sure there are some people in the room today who are much more expert around what's been going on, particularly in New South Wales Health, and some of the nitty-gritty about how this is going to work. So I'm really just trying to present a bit of a general picture. Happy to take questions and answer to the best of my ability, but there may be areas that I'm not fully up on, so please bear with me. Just a bit about... what we're going to cover, just give you a brief overview of what was actually agreed at COAG back in April this year. What are the key elements and some of the timeframes that the government's committed to delivering on. Where the broad implementation is up to date, what NCOS has identified as some of the issues might be around that reform model. A quick look at some of the broader issues that we think there are for health NGOs, and a little bit about what we've been doing in the reform context. So the COAG agreement was made back in April in response to a number of issues. We generally have a pretty good health system compared to world standards, but we are facing a number of issues in terms of declining workforce, increasing demand for more costly acute services. We have a very limited funding base. We have quite a complex service system with fragmented responsibility for funding. We have inequalities in a number of areas, particularly around Aboriginal health, rural and remote health, mental health, oral health. So there are some areas that still really stand out for us. And you might remember that the National Health and Hospital Reforms Commission came out with 123 recommendations around reforming our health system. And this isn't just Australia, this is happening across the globe. The UK has done a lot of work around primary healthcare trusts in the NHS. Also New Zealand, Canada, so there are quite a few other models of reforms out there. So in April 2010 this year, we had the agreement with all states apart from Western Australia signing up to reform of our health system. It was looking at a number of areas, particularly around public hospitals, primary healthcare, governance, funding and performance. And the aim was to improve the quality of care, provide more seamless care, and I think really the emphasis has been around developing a more sustainable funding base for the future for our health system. And the May 2010 budget saw this accompanied by a funding package of over $7.3 billion, of which was a little bit broader than the original COAG agreement. It also included funding for e-health, some money around aged care, mental health, more hospital beds, emergency department targets, elective surgery targets, and a number of other measures. So the guts of the agreement as it was in April was to establish these new entities called local health networks, the agreement was for local hospital networks, but in New South Wales we've decided to call them local health networks, so you've probably heard a bit about those in recent months. And they'll be the operational managers for small groups of public hospitals, either in a geographic area or a functional area, a functional sense. The Commonwealth will become the dominant funder of public hospitals at 60%, which is a shift from what it does now, and that'll be based on activity-based funding or the efficient price of providing a hospital service, although the smaller rural and remote hospitals will still retain block funding, so that's not across the board. We'll have another new entity of primary healthcare organisations, which for the moment are being called Medicare Locals, although I know there's a bit of contention around the name in the sector and its connotations with Medicare. And the Commonwealth will take over full funding and policy responsibility for some categories of primary healthcare services. That's not across the board, but it will take over all aged care. And there'll be a new performance and accountability framework that'll be supported by new Healthy Communities reports and new hospital reports, and this will be overseen by a National Performance Authority. And we'll also be looking to have the introduction of personally controlled e-health records. So they were sort of the key guts of what was agreed. Now, the local health networks in New South Wales, it looks like we will be having 18 LHNs. 15 of those will be geographic, with 7 in rural and remote areas and 8 in the metro areas. And there'll be 3 functional LHNs, so there'll be a children's and paediatric services, a forensic mental health, and there'll also be a specific cluster for St Vincent's health services to retain their clinical structures. The LHNs will be run by a governing council of between 9 to 13 members, headed by a chair, and the day-to-day will be done by a chief executive. Now, in addition, in New South Wales, we'll also be having 3 clinical support clusters, and these will be Northern, Southern and Western. And they'll take on a number of the bigger picture functions, some more of the clinical network support. New South Wales Health has got quite a useful guide on their website as to what the roles of the LHNs will be and what the roles of the clusters will be. It sort of looks like that. It just divvies them up. And it's still unclear, I suppose, as to what exactly will fit in some of the clusters and what will be retained as a Department of Health statewide. So there are still some issues that will need to be resolved. But it's all happening very quickly. The LHNs will start operating on the 1st of January next year. The area health services will be abolished, and there'll be a 6-month transition for the LHNs to becoming fully operational by the COAG agreed date of 1st of July 2011. So it's all systems go. Around primary healthcare, so the Commonwealth is taking over full funding and policy responsibility for some services. However, the states will continue to actually deliver those services on the ground for the short term, and there'll be no immediate change for the next few years. To give you a snapshot as to what was listed in the COAG agreement, and I know there's a lot on there, the Commonwealth essentially is taking over the community-based primary healthcare for the more moderate, less specialist services, less complex, I suppose. The states will retain oral health, ambulance, justice health, acute care, hospital avoidance, sexual health and general sexual health services. And there's a bit of a grey area, and these are the tricky ones, and these were to, according to the agreement, we're supposed to be going back to COAG in December of this year for the states and territory governments to agree with the Commonwealth who was going to get them. It now looks like COAG's not happening in December and will actually probably be happening in February, although the Prime Minister hasn't formally announced a date, so we're sort of waiting to see. So there's still some discussions that need to happen around community health promotion and population, including preventative health, which we see as a really big area, drug and alcohol treatment services, children and maternal health services, community palliative care, and then specialist community mental health services. So they're pretty big areas that are probably particularly relevant to the non-government health sector because they're where we operate in that space. So we're still in a bit of a limbo around this area. In primary healthcare, we're looking at the establishment of these independent primary healthcare organisations, Medicare locals, and their overarching function is really to plan and coordinate the delivery of primary healthcare services at the local level. Initially, they'll be concentrating on access to after-hours GP services, and in the medium term, they might be helping deliver programs around coordinated case management around diabetes, some delivery of the early intervention mental health programs, and also aged care. And longer term, there have been flagged that they could take a broader role in actually possibly providing primary healthcare services themselves or health promotion, that bigger picture work, but there hasn't been a lot of detail as to how that might occur, and very much focused on the moment at that more clinical GP end of the primary healthcare spectrum. There's very little detail in the COAG agreement and also in the discussion papers that have come out from Department of Health and Ageing as to the governance and operation of Medicare locals, how they'll actually run. We do know that the first round of around 15 Medicare locals will be operated by divisions of general practice. They've been given an exclusive VOI to tender for the first round. They're still waiting to see what the actual specifications are for that tender, but the well-performing high-end divisions are likely to be the ones that take over at least the first round of those Medicare locals. The government has said that it would consider opening up the second round for 2012 to a broader market. And a lot of the commentary has been that there are some very well-performing, for example, Aboriginal medical health services that should be considered. And again, there is some concern. I think NCOS would be one of those voices that say, well, there are some very good divisions, but again, we think they come from a more medical model of health and perhaps aren't as strong on some of that broader social determinants of health approach that perhaps some of the Aboriginal medical health services might be quite good at. So that's something that we're keen to work with and make sure that we do develop very good relationships with the divisions of general practice. And I think that's an area where, particularly the sector, and I think you as service providers, there's opportunity for us to really work there.